meeting. And covered, besides being an actual word, stands for an abbreviation for our study. And this is not easy. Try to get COVID into an actual word to describe a project. So covered stands for COVID-19 Evaluation of Risk in Emergency Departments. And the specific aims of the covered project are to answer the two most important questions that is on every emergency provider's mind right now, which is what is my risk of contracting this potentially deadly infection through doing my job, which I'm committed to, and then are there ways that we can try to understand how to reduce that risk? So COVID-19 is the first major deadly global pandemic in over 100 years, since the Spanish flu in 1918. And it is the third deadly novel coronavirus epidemic since SARS in 2003 and MERS in 2012. And like those two coronavirus infections, COVID-19 cases seem to be overrepresented in proportion in terms of healthcare workers who have become infected. And it's presumed that caring for people with contagious and potentially deadly respiratory viral infections poses a risk to healthcare workers acquiring that infection. But the dynamics of transmission of these types of infections has never really been well understood. Healthcare workers certainly would be expected to be overrepresented in testing and identification. And healthcare workers also are part of the community. Hey, what? Mute? Who's ever beeping? Try to mute
I just muted that.
Okay, thanks everybody. I was on a good roll there until the beeping started. So it's the dynamics of viral transmission and acquisition in the healthcare setting has never really been well understood. Healthcare workers may be overrepresented because we tend to be the ones who are tested so as to be able to protect that workforce and protect the patients that we take care of. And we're also out in the community where we may acquire infection like anybody else. So covered is the very first major prospective epidemiologic project, surveillance project, to understand the dynamics of a contagious respiratory virus which has significant healthcare consequences in the setting of emergency care. So this has never been done, and we may not get many opportunities again to do something like this. But the whole point is that if we can take advantage of this moment, work hard together, we can learn some things that are going to be very, very important, not just to the curiosity, but to apply them in future types of healthcare challenges like we face today. This project is among the CDC's highest priorities. I can let them talk in a few minutes. And I think the emphasis to get this going reflects the fact that the American public is extremely grateful to emergency providers for the work that we're doing right now. And we can pay them back by answering some questions to figure out how to protect and maintain that healthy workforce so we can be there for people as we go forward. So Nick, if you would just go to the next slide, I'm going to show you the agenda. That was the welcome. I'm going to introduce the sites and you site investigators. Key personnel, we'll talk about obtaining approvals, identifying study staff and potentially eligible participants. Site budgets, we'll explain our plan for central laboratory testing, things to do today in order to be prepared for specific site readiness calls, which we'll have with each of you. Next slide, please. So here you are. You should be able to find your name on the list. Let's see, Steve Lim, there he is. So I can't tell you how inspiring it was when the word got out about the covered study and how many people, how many centers contacted me from across the country. So many people believe in this project, and they almost like it's a cause, not a study or a project. And a lot of very talented people wanted to be involved. The study had to select the 20 best sites and site investigators. So congratulations, you're among that group. You guys are leaders in emergency medicine. I greatly respect your interest and commitment to this project. I've talked with all of you personally. That's been a lot of fun. It's not as much fun to have to do this over Zoom to 20, 30 people at a time. But I'll just read through the names, and you could give yourselves a pat on the back. Justin Carlson, Howard Smithline, Stacy Trent, James Paxson, Brian Driver, and Johanna Moore, Lily Lee, Rich Rothman, Steve Lim, Lynn Richardson, Makani Chrism Straker, Kimberly Souffrant, Phil Giordano and Kurt Weber, Walter Schrader and Michael Kurtz, Phil Maurer and Greg Moran, my friends from UCLA, Brett Faney, Greg Volturo, James Galbraith, Rob Rodriguez, Mohammed Idris, Mark Steele and Amy Stubbs, Elizabeth Krebs, Steve Ling, and Brian Fuller. So there you are. Thank you very much. So appreciate the opportunity to work with you. Okay, next slide, please. All right, so these are key personnel that work together to oversee this project. There's probably more people at each of these sites as well. So I'm Dave Talon, me. Our project director is Dr. Anusha Krishnadasan. She's on the call. You'll be interacting with Denise Tritch. She directs our contracts office, Oliveview UCLA Education and Research Institute. And that's very important because with funding, we're going to have to establish contracts. We're going to have to get you money to get started. So she's very important. Always be sure to look for emails from Denise. We have the Iowa City team. So this is a partnership between UCLA and the University of Iowa. Nick Moore, who's an intensivist and an emergency physician, heads that group where we'll house the Data Coordinating Center directed by Carrie Harlan and Kelly Wallace. I should also mention in the UCLA team, Bill Maurer is one of our biostatisticians who has been supporting the methods in this study, and Greg Moran, as you all know, is my longtime research partner who will also be helping supervise the project. And then, thank you. We could not have done this without the help of the CDC. We've worked with them through Emergency IDNet for 25 years. And it's meant a lot to me that the Centers for Disease Control realizes the importance of emergency specialists in looking for, detecting, figuring out how to control and treat emerging infectious disease problems. We've been doing this a long time, but nobody expected that because of that relationship, we would be in the position to try to do something so important like this. So I'd like, and on the CDC team, that's headed by Cliff McDonald, Department of Healthcare Quality and National Center for Emerging and Zoonotic Infections, Preeta Cuddy, and Scott Santabanez, who's worked with Emergency IDNet for a long time. Before I turn this over to Nick, I particularly want to thank the CDC. This is a really hard thing to do that we're going to try to do here. We had to put together the methods for this study over just a couple weeks, identify funding, discuss methods. People from the CDC work with us day and night and on the weekends. And believe it or not, to put together something like this and to get it funded so quickly is not easy. I have never had a challenge like this. This is going to be hard for you too. But I can tell you, everybody at UCLA, University of Iowa, the CDC in particular, has been completely committed. We're going to have to get this going soon. Pandemics don't come around every day, you know what they say, to really take advantage of this opportunity. And that means that, you can't just mail it in. We're going to have to walk these subcontracts through, figure out how to recruit participants, identify the type of help we need in terms of study coordinators, phlebotomists, pay attention to our emails, return phone calls, things like that. But if it's any reflection, of your commitment, I can just tell you right at the top of this, from the U.S. Centers for Disease Control, these partners could not have been more supportive. So I want to thank them. I don't know, Scott, do you or anyone else from CDC, do you want to say a few words before I turn it over to Nick?
Oh, yeah, this is Scott. I can say a couple words, and if Cliff's on, he may want to add. Just to reiterate what David said, this pandemic is really unprecedented. Those of us who've been through previous responses, Ebola, H1N1, Zika, we've never seen something quite of this magnitude in recent years. And, unfortunately, the cases are going to continue to accrue, and people will continue to be affected. And we really need to protect our healthcare staff, especially our emergency department staff. And so that's a high priority for us. The science around understanding this virus is evolving. This is a new virus. It's not like Ebola, which we had 40 years to study, or influenza, which we've known about for many, many years and been able to study. This is something totally new. So we're defining the science as we go. And so we really appreciate you partnering with us in that. And when David first pitched this idea to Cliff McDonald, we were very interested in this. We were able to get support from the highest levels very quickly. And as David mentioned, even with the red tape that often, accompanies working within the government, we were able to get things moving pretty quickly. So we were glad to see that happen. So I'll just say, thanks to all of you for the clinical care that you're providing to patients, and thanks for partnering with us as we try to define the science around this and work on that together.
All right, well, thank you, Scott. Nick, why don't you take over and lead the rest of the discussion?
Yeah, great. Thank you, Dave and Scott, for all of the work that has gone into this. I'm Nick Moore from the University of Iowa, and I'm going to be talking today about what the next steps are for us to roll this out across the network. We have 20 really qualified centers, and we're really excited that all of you have agreed to participate in this with us. We think that this is really important work and going to come up with some really interesting and important findings. So we're going to go through the nuts and bolts of the study a little bit. All of you in your site packet received a copy of the proposal. We also had some site readiness checklists in there for you, and some overview information about the rest of what we're doing. So I'm just going to touch on that. I'm not going to go through all of that in detail, but after we go through the study, we can take questions that you have. This study has been proposed as public health surveillance. And what that means is that our view is that this is not human subjects research. That view has been shared by the IRB at CDC, the IRB at the University of Iowa, and the IRB at Olive View, UCLA. So when we move forward in this data collection effort, most of us are familiar with the use of central IRBs. We're familiar with the use of IRB-approved language. This data collection effort is a little bit different. The consent process is a little bit different, and although we'll still have rigorous participant protections, the process in your own institutions will be different. The first step is going to be that we all at our own institutions will need to get a determination from our local IRBs to agree that this is public health surveillance instead of human subjects research. We included in your study, in your site packet, the determinations from the CDC, the University of Iowa, and UCLA, which could be really useful as you seek a similar determination from your own institutional review board. We anticipate that most or all of your institutional IRBs will agree with that determination. Actually, we've already heard from some of you that you've sought that determination from your IRB who has already agreed. So thank you for being on top of doing that. That will be the first step for each of the sites, and then we will we'll want to get a copy of that determination from each of your sites before our site readiness call and before your site is activated to start recruiting participants. The next step at each of your sites is going to be to get approvals from your own department leadership. That will likely include your chair, your nurse manager, and the managers or supervisors of your non-clinical staff in your emergency departments. The purpose of this is to kind of share the study, to talk about what the study might involve, and to get the assent of those people to recruit people at your site. Each of you, and you saw on the slide at the beginning, each of you, I believe, have already identified a site PI, and many of you have already identified study coordinators. While we're seeking these approvals, we want to understand who's on your team, your site PI, study coordinator, maybe other study coordinators, and then we're all at our own sites going to need to come up with some strategy of getting test samples. And those samples are going to be blood. We have now, which is an addition since you saw the site proposal, we're going to be collecting both blood and self-administered nasal swabs every 2 weeks during the 12-week study period. Those blood samples could be drawn in a number of different places. We've included dollars in the budget so that if you needed to hire a nurse or a phlebotomist to collect those specimens, you would be able to do that. As I've talked with other site PIs, there are probably places where they will be using emergency department staff before or after their shifts, nursing staff. There are places that are likely to be using a research clinic for those specimens to be collected. There could be places that are hiring somebody part-time. So a lot of different ways that this can be done, but we recognize that in each of your sites, there's been some kind of human subjects research slowdown. You may not have the same clinics or the same flexibility in how you might collect specimens as you would have had 3 or 4 months ago, but we trust that each of you will be able to figure out how you can collect those specimens at your own sites. Those specimens will be collected every 2 weeks, and that will be a kind of rolling 2 weeks. So it may take a week for you to get all of the participants at your site enrolled, and you may be collecting blood during that week, and then it's fine that over 2 weeks later that you have that same rolling blood collection to try to flatten the amount of work that you have to do during each of your study weeks. The next step is going to be to identify populations of potential research participants in your study participants in your study. Those participants will fall into one of 4 categories. We're looking for each site to provide about 80 study participants. And we want study participants who will be available over the entire 3-month study period, who are going to be working in the emergency department for the majority of that time, people who aren't going to be on rotations in other places for the majority of that time. But we recognize that each of the sites could be quite a bit different in this. And so we want to allow some flexibility for the site PIs to try to identify people in each of these cohorts. And we, during your study readiness calls, will be talking about these cohorts with you. The first 2 cohorts are cohorts of physicians. Those could be residents or they could be attending physicians. The idea is that we want people who have that level of patient contact. They're going into rooms, they're seeing patients, they're using personal protective equipment. But we recognize in many of our sites that there's a cohort of physicians who are likely to be intubating patients who have acute hypoxemic respiratory failure related to COVID-19 infection. And there may be a cohort of physicians who are unlikely to be doing that. So the physicians who may be more likely could be some of your faculty, it could be some of your senior residents, depending on how you're going to be managing these patients at your site. Some sites now have rolled out intubation teams, and for those of you who are at sites that have rolled out intubation teams, we want to talk with you more about how that can be incorporated into the study design. There are probably physicians at your sites that may not be likely to intubate. That could be other faculty physicians. It could be people who are working in the same part of the emergency department, but maybe they're more junior in their residency training, and it's unlikely that they're going to be intubating a patient with known or suspected COVID. That would make up the second physician cohort. we know that those two cohorts are going to have a significant amount of crossover. And so in our analytics strategy, we're really looking at what the exposures are for each of the individuals more than which cohort they were assigned to. But we want to make sure, especially for sites that have many more than 40 resident and faculty physicians at your sites, we want to make sure that we have some representation of people who are likely to have exposure to aerosol generating procedures, especially intubation and maybe cardiopulmonary resuscitation, and another cohort of physicians who are much less likely to be exposed in that way. We have two additional cohorts that we've defined for this data collection effort. One of those are emergency department nurses, and the other are non-clinical, non-exposed control participants. Emergency department nurses are going to be working in the same clinical setting as the physicians, but we really want to understand what the risk is to our nursing colleagues here. And for our non-clinical controls, really we're trying to identify clerks, maybe social workers, maybe case managers, maybe pharmacists, maybe billing professionals, groups of people who are in the emergency department environment, but not with direct patient care responsibilities. The goal here is that we want to understand what the attributable risk of exposure to patients might be. And we recognize that for people who are working in the emergency department, some of the risk of being in the emergency department is being exposed to other staff members in the emergency department. Some of that risk is that they're leaving their homes every day. They're not truly completely socially isolated like they might be if they didn't work in the emergency department. So we want to understand what the risk is to those people being in the emergency department environment, and then what the attributable risk or the comparative risk of those physicians who are performing procedures and nurses who are providing care might be. We've gotten a few questions from some of you about site budgets. When we initially proposed this budget to CDC, we had gone through and said, well, what do we think it would cost to be able to run a data collection effort like this for 12 weeks? And we know that during that 12-week period of time, we have a number of study participants who are going to be filling out surveys. We know that we'll need to be drawing blood from each of those participants on a schedule. We'll need to be following up on people who might not get surveys completed, validating data to make sure that we have high quality data as we're collecting all of these responses. And we also know that some of that work is going to extend beyond the 7-week or the 12-week period. We also know that before the study starts, there's a fair amount of work that goes into the ramp up for that, getting your contracts done and kind of pushing this through whatever approvals are required at your own sites. And that afterwards, as we're getting the data collection finished and making sure that we have contact information and those kinds of things, that it's going to take some study coordination. We have estimated that across the sites that the cost of doing those things is about $60,000 in direct costs. We know that there are some sites where some of these things are going to be more expensive than other sites, but this was a way that we thought we would be able to get a budget rolled out very quickly to each of the sites to fund the staff that you need to do some of this work, to retain staff who may otherwise have been furloughed because of a ramp down in local human subjects research operations. That $60,000 is not inclusive of the facilities and administrative indirect costs. We know that each of your sites have a different federally negotiated indirect cost rate. And so we will be providing funds to cover those indirect costs in addition to the expenses that you'll be incurring as part of the direct costs. You can be flexible with how those dollars are used. We had anticipated that some of those dollars would be used for a PI fee. We had anticipated that some of those dollars would be used to pay a study coordinator, probably full-time during the study period. We had anticipated that some of those dollars would be used to facilitate the drawing of those blood specimens. And that in some of those places you might be hiring somebody to do that. In some of those places you might be paying nurses or techs during time when they're not working in the emergency department, or you may be paying a clinical research unit. But we wanted to give you the flexibility to be able to solve those problems in your own sites really flexibly. We also, out of that, there will be some shipping costs, and we estimate for each of your sites that that's going to be someplace in the $1,000 to $2,000 range, maybe up to $2,500. But it allows some flexibility for you to to allocate funds between those line items for whatever it takes for you to get this study done at your own place. We also, in addition to that, are intending to pay all of the study participants. And you saw a draft fee schedule for that in your site packet when that was sent out a few days ago. But those funds we intend to distribute centrally. So after somebody consents to participate in the study, they'll receive in the mail a gift card, and that gift card will be loaded with value each time they complete one of the study surveys, each time they give a blood sample or a nasal swab. And so every week we'll add value to those cards to really compensate people for the time that they're spending in conducting the activities of the study. We also laid out a site payment schedule, and that's really more for the facility charges, where that $60,000 is paid. For each of you who have already put your name down and said, yep, we want to participate, we're working on the subcontracting, those sorts of things, just for doing that, once we get the subcontracts awarded, we will be awarding $10,000, and then the rest of the fees are based on performance of the milestones. We anticipate that all of the sites here will be receiving all of that $60,000. The enrollment fees are a per participant fee, and we would anticipate that as soon as you're finished with enrollment that we'll be paying that out, and then the final fees really are just at the end of the study to pay whatever other expenses you might have had up to that $60,000. Subcontracts will be awarded through all of UCLA, and these are going to be subcontracts because this award came as a supplement to Emergency ID Net, the CDC-funded network. So all of those subcontracts will be worked out by Denise and her team with each of your sites, but we're hoping to do that very rapidly. We provided a letter in the site packet to each of you that has some details that came from CDC, ensuring that this study is approved and that the formal notice of award is coming. We anticipate that that's going to be coming very soon, and we hope in the next day or so to have draft subcontracts out to each of your sites. We talked already about the participant compensation that's coming from the main site, and really the reason for that is so that we can get this up and going very quickly, because we different from how most other clinical trials are starting, we're hoping to have this whole project started really in a matter of a very short period of time. Dave, maybe I'll turn it over to you and let you talk a little bit about central lab testing.
Thanks, Nick. Good job. So, yeah, we're working out the details of this, but we anticipate working with a commercial lab. And that one of the sort of interesting incentives of the study is that I think a lot of us and our colleagues were interested to know whether or not we even had this infection. It now appears clear that more than we expected, people may not experience significant or recognizable symptoms. It may even be asymptomatic and have the infection and generate IgG antibodies. I hope, for the world's sake, that having IgG antibodies gives us some degree of protective immunities for some amount of time. So we do want to, in addition to this being our marker to determine if someone develops infection through seroconversion, I think it'll be interesting to the people involved to get their results back. So the plan would be to have these drawn every 2 weeks. We'd also collect nasal specimens. These are not the uncomfortable nasopharyngeal specimens that someone else has to put in, and that would, engender some risk to the person. This can be done by the participant themselves. Those would be stored, shipped in some batched way every week or twice a week to a central laboratory. And then the results would have a short turnaround time so that the participants who are curious about their serology or PCR testing would be able to get those results pretty timely. And of course, we'll do this at baseline and then every 2 weeks through the end of the study. Yeah, and then we will have a separate budget. I think Nick covered the line item that we've made for shipping. And the cost of the lab tests will not be borne by you at the sites. This will be paid for centrally through a separate budget. So, Nick, is there anything else that I should cover with regard to the laboratory specimens?
No, I think that the real take-home message here is that this isn't going to require a lot of processing at the sites. We anticipate that this is going to be a blood draw, storage, and then sending the specimens, but this isn't going to require that these are spun down or that they're processed in any way in your laboratory other than just collecting the specimens and then shipping them.
That's right. Okay. All right. Let's go on.
All right, Anusha, you want to take over here to talk about the next steps?
Yes, sure. Hi, everyone. Yeah, so I know I've heard from many of you. Actually, I think I've heard from almost all sites confirming participation. So I'm happy to hear you're all in. The next thing I want, as soon as possible, I know some of you, again, have sent this to me, is your contracting folks' contact information and your site PI and study coordinators. So these are the people that put on a list and will need to be in contact with, starting tomorrow. You also please send your information to the Data Coordinating Center, to Carrie and Kelly, the list, the name, your email address, and this is so that you can get access to REDCap as soon as possible. And we set up a study email address. You see it at the bottom, emergency IDNet covered at uiowa.edu. That email gets sent to me and to the DCC. So you just send everything. You can just start sending emails today to that email address. And the next slide, I think we're going to be talking about the site readiness calls. And basically we would, I know there's going to be a lot of specific questions that come up at your sites. Feel free to email us as they come. We will try our best to answer them as soon as possible. But we will also be scheduling a call with each of your sites. It'll be Dave or Nick and me. And basically when you've gotten your IRB determination and sent it to us, you've identified your study staff and phlebotomy setup. You've identified potential participants, meaning that you gathered all your email lists together. I don't know if we didn't talk about this specifically, but all the participants will be consenting via REDCap. So this is going to be an e-consent. So we'll be screening them, enrolling them through REDCap. So we'll basically be sending them a link to the screening form. So we'll need that email list from you. And then, so you'll see the subcontract draft, I think, latest Thursday. And I just want to make sure that it's routed to the right people as soon as possible. This is usually a kind of a rate limiting step if you guys are very familiar with these subcontract setups. So I'm hoping, like we've seen with the IRBs, the contracts offices will also fast track these contracts through as soon as possible. And then we're going to be sending out data collection forms to everyone today to review and look through carefully and send your feedback. And I think we're going to send those right after this call. We'd like your review. I think we said by Friday, if possible. The earlier, the better, though. If you can get to them by tonight or tomorrow, even better. And then, yeah, send this all to the study email address when you've done that. Attach your copy of IRB determination, and then we'll set up those calls with your sites and answer any questions that you have.
Okay, now we got time for some questions. There will be a lot of promotion of the covered project through ASAP. I'm probably going to talk about it this afternoon on MRAP. I'll see if I can get that slide with all of your names and institutions listed for all those people to see. And so, I hope there'll be a lot of enthusiasm. I think this will be a shot in the arm for people who are going to work every day. You guys have some questions? There's a lot of you. I realize that. And we will have time for more detailed discussions when we have the specific site calls later.
So I'm just reading on the chat, Dave. Elizabeth Krebs wrote, will all the consumables for the specimen collection be provided to sites?
I think for the nasal PCR, there'll be swabs and transport media that will be provided. For the serology, we'll have to see. It may be just a simple serum separator tube, but if that's, if that type of supply is something that the sites find that they need or would have a problem getting at their sites, we'll figure out a way to get that to you.
Someone asked, can NPs or PAs be enrolled?
Yes. For the, probably they're not doing intubations, but for the non-intubating sort of physician cohort, people who do physician type of patient care, histories, physical exams, things like that, interacting with patients would also include nurse practitioners and PAs. And often in academic programs, they're the more constant employees for a study like this. So in a way, in some places, they might be preferred participants. Good question.
All right. How long can samples sit in fridge freezer before being shipped?
Wow.
These are really specific.
Going deep here. Yeah, I think, well, I think they will be shipped probably every week or so or twice a week. And from what I've learned, I've had a lot of discussions with commercial laboratories that they can stay frozen for quite a while. So I don't think that will be a problem. For those of you who are interested in lab specimen storage and transport, I believe that they would go on in a FedEx container over dry ice, which is done pretty routinely. As you know, all your major medical centers have send out labs and things like that. But we'll make sure that everybody understands what to do and has the proper supplies and knows where to send things before we begin. Promise.
Looks like the next one has to do with non-clinical controls, whether they're on site. Our intention is that the non-clinical controls should be on site. We're trying to get people who have some exposure to other healthcare workers in the emergency department. So we want to identify people who aren't just working from home. Do blood specimens need to be centrifuged? Dave, you've been talking to the lab. We don't anticipate that there's any centrifuge.
Yeah, you shouldn't have to do anything but draw this into a serum separator tube and put it on ice. Shaken, not stirred.
What's the window which samples can be drawn from all the different subjects each week? We want to try to capture data about every 2 weeks. So we anticipate that that's going to be on the date or plus or minus 2 days. So that will be kind of within the week. So that gives you a little bit of flexibility to get people in and scheduled and work around people's days off. But we anticipate that's going to be plus or minus 2 days. How about EVS staff as a control group? Dave, you want to take that?
EVS?
Environmental services, I imagine.
Environmental housekeeping.
I think we talked about that and we thought probably not, because they would have some additional sort of atypical type of risk and exposure, right? Because of potentially being there handling biological specimens. So I'd say no to that one.
Yeah.
But if you get desperate, call us back.
The next question is about patient participants who have baseline positive serologies. If somebody has already seroconverted, so in the initial participant survey, we're asking if people have had known infection, but it's possible that somebody will not have had known infection and has already seroconverted. We would want you to replace that participant with another participant for the study. Obviously, for that first participant, we'll still pay that person for the things that they've done, but we would replace that participant if it's positive at the beginning of the study. For somebody else who seroconverts during the study, that person then stays in and we follow their symptoms during the course of the study.
Yeah, there's symptoms, and we're also sort of interested if someone seroconverts, if their role will change, their work might change. Let's say they would start doing more shifts or more intubations, things like that. So we'll catch a lot of interesting meta results. For example, we're going to look at impacts on families. Rob Rodriguez has proposed, Rob, I don't know if you're there, I can't see everybody's name or everybody, but he's interested in the effects of on anxiety to healthcare workers, stress and things like that. So we'll get a lot of other interesting information from this project.
The next question, what's the expected swab? This is a PCR. It's a self-administered nasal swab, but it's still to be done for PCR. Has there been discussion on providers disclosing those results? And our intention is to feed that back to the study participants. We don't intend to notify people's employers or local public health authorities. Obviously, we would anticipate that study participants will be disclosing those results to their local employee health, but it's not something that we're doing for people. Dave, do you have anything you want to talk about with that?
Yeah, the project can't be people's doctors. And actually, CDC, you can comment, has no guidance regarding what you do with, asymptomatic people who turn out to have seroconverted or you find a positive PCR. So we would just, have a general statement that, with these results that people should follow up in their usual means for evaluation.
Yeah, I think that could be really interesting, especially if we have people who, because we'll have nasal swabs at the same time, we presumably will have some data. If there are people who seroconvert and are PCR negative, then we'll need to decide what the people's employee health clinic is going to need to decide what to do for return to work and those sorts of things. The next question is about, from Walt, you listed 4 groups of physicians. Do you want 20 in each group? Do you want 20 in the uncertain group? Great question. When we had, in your site participation survey, we listed 4 groups of physicians, really because we are most interested in the people who are likely and the people who are unlikely to be intubating. Unless there's a problem with sample size at a site, we don't intend to recruit any of the participants who are either unknown or with intermediate probability of intubating. We really want to capture the highest risk and the lowest risk people. And we anticipate that some of the sites, we may have to pull from that middle group and decide how many people we're going to pull into the other groups. When we're talking about recruiting 80 people, though, that's 40 physicians, 20 nurses, and 20 non-clinical staff. If you're at a site where those numbers seem difficult, we're happy to talk with you about that more to see if there are ways that we can identify some creative groups within your settings to fill out that sample size. We anticipate more interest than the 40 by 20 subjects. If more people want to participate, how should we choose participants? Great question. We're going to talk with you about that during the site readiness calls, because it's possible as we start to have these calls that we'll find that there are some sites that aren't able to contribute all 80 participants, and we may be able to recruit a few more at some of the sites, but we need to see what that looks like study-wide so that we can achieve our sample size of 1,600, recognizing that each of your emergency departments are functioning very differently right now. Do you need a -80 freezer or a standard freezer? Dave, do you want to take that one?
I don't know yet. I'll find out.
Yeah. That we should have clarity on which central lab we're going to be using and how that process is going to work within probably the next week. Should we exclude PGY3 residents who will graduate in June, assuming they would graduate in June and not continue? However, some might stay in town, include those. We have not intentionally excluded PGY3 residents. And the reason for that is because we anticipate that in some of your emergency departments, those might be the people who you've tapped to do the airway management, to do intubations. In a perfect world, we'd love to be able to follow those people even after they graduate. You may also have residents that are in the emergency department for maybe 8 of the 12 weeks and then are going to be off service. During your site readiness call, we'll be talking about those cohorts and how we can identify a cohort that best satisfies the needs for the study. We recognize that as a pragmatic study, probably nobody is going to have this beautiful cohort of 20 physicians who are intubating all the time and 20 who are intubating rarely, et cetera, et cetera, et cetera. And so the goal here is going to be to make this practical at your site so that we can collect information to answer an important question.
Yeah, we could also, we anticipated this with the graduation, of classes in June. You could rotate one person out and then rotate somebody in as an intubator, let's say for the last 4 weeks of the trial period. So that could be done as well.
The next question is about attendings who are mainly supervising intubations. Dave, do you want to take that one?
I think so, although I thought intubation was sort of you, but yeah, I mean, we're interested, like Nick was saying, in the highest risk exposure, which is really, aerosolized procedures, intubations, cardiac arrest of the people right there, or as close as you get, with your glide scope. So I think physicians who are supervising intubations are sort of in the middle. We would prefer to have doctor or doctor type people who don't participate close to an intubation versus those who actually directly do the intubation, and not sort of hybrids of that if possible. Would you agree with that, Nick?
Yeah, I would. I think that this is another thing that could vary quite a bit between sites. There are some sites now that are not having residents intubate COVID positive known patients. If you're at one of those sites, then you wouldn't put the residents into an intubation group. There are other sites that are saying, well, our senior residents can intubate those patients, but we don't want to expose any more people, so we're going to have faculty stand outside the room and kind of supervise either kind of through the window or in some other way so that we're exposing fewer participants. In those cases, we'd say that the faculty participants are not intubating. I think that what the question probably is about people who are supervising physicians, not holding the glide scope, but within kind of an arm's length, that are actually participating in the intubation itself. And those are people who we would consider having intubation exposure. Lynn asks, will the weekly surveys be administered electronically through REDCap? Yes, they will. That will all be centralized so that the participant interest survey is going to be a link that we provide to each of you. So as you figure out who in your sites would be good people to participate here, what does your population look like, you can identify those people, share the participation link, that they can click on that, go in, express their interest. Also, we have some of those inclusion or exclusion criteria. If you had COVID before, do you expect to be intubating during this period of time? Are you a physician or a nurse? And then at the end of that, they'll provide their contact information. With that information, we with you will select what the study group is, and then to the study group we'll send the consent document for electronic consent and the baseline enrollment form, and people who have signed that and completed the form are the people who are in the study. And then each week, the surveys that will go out for symptom screening and PPE use and availability, those kinds of things, that will all be automated. We'll be communicating with study participants through their email and or text messaging. People will be able to choose that during their registration with the study. The next question is, we have 2 hospitals where physicians intubate. We must limit enrollment to physicians working only at the main site to limit confounding. PPE access is similar at both sites. Could we just do the survey for both hospitals and note where the physicians took shifts, where different shifts took place each week? Yeah, we recognize that there are some places where you may have people who are at 2 different sites. We can discuss that during your site readiness calls, but we think that especially if you're able to collect data from both of those sites, that's okay. It's better if you have a group of people who, for a particular time period, is devoted to one facility, and then maybe 4 weeks later moves to a different facility. But it's okay for people to be working in different facilities where you have access to the data. Where we're a little bit more concerned is if you have 5 facilities that people are going to, and only 1 or 2 of those facilities do you have access to the data. Because since we're looking at the rate of, or the risk for seroconversion, we want to be careful about people having significant risks, significant intubation exposure that's not part of the sampling frame for what we're collecting for the purposes of this study. Is there any chart review data that will have to be submitted, Lynn? Yeah, there is. The data are not real detailed, but there are some data about the study participant and things that would have been available in the medical record. Some of those parameters are things like how long they were in the hospital, how long they were sick before they got intubated, those kinds of things. For each intubation event, the participant will fill out an intubation form for those sites that participated in the NEAR registry. This is a similar process to the NEAR form, although the form is much less extensive than the NEAR registry form was, and all of the detail that was required for those intubations. There will be a companion form that the site coordinator will fill out for each of those individuals who is intubated. Do you know if sites need to figure out what company to use for shipments, aka FedEx, or would you use a central shipping company and set dates for pickup? Love World Courier with other studies. This is something we hope to have sorted out within the next week as we find, as we identify which central lab we're going to be going with and all of the details for how the shipping will occur for that. But we'll provide additional guidance on that. Are you expecting that we'll have our 80 individual participants identified before the site readiness call? No, you don't need to have the names of all those people, but we, during the site readiness call, would want to know that you've thought about what those groups are and how many people are in those groups. So we would hope by the site readiness call, if you said, you know, we have an intubation team and there's only 5 people on that team, and even if we got all 5 of those, nobody else is going to be intubating, that would be the kind of thing we'd want to discuss during the call. If you said, no, we have, you know, 100 faculty and residents at our site, and they, yeah, we can identify a high risk cohort and a lower risk cohort, and there are plenty of people here, that would be the level of detail that we would need for the site readiness call. So if you can use that worksheet or the site readiness checklist to identify, you know, I think that these are the people who are in the likely to intubate cohort. I think these are the people who are likely to be in the unlikely to intubate cohort. And so we have, you know, 45 in one group and 10 in another group. That's the level of detail that we'll need for that call. Do you have a data use agreement template available? Anusha, do you want to take that one?
Yeah, we have one if you need it. So we can send that out.
And that'll probably be part of the subcontracting process, Anusha, right?
Right. It'll probably be in the subcontract. That's okay.
Yep. Next question. Identifying 20 non-clinical folks seems like a stretch. We certainly don't have 20 clerks in the department. Who do you have in mind for this group? Each department is going to function very differently. So there are some departments, so clearly there aren't going to be 20 clerks at any one time. Some departments have clerks and billing people and insurance people and maybe some social workers. Think of who you think that you have there. If you don't have 20, we either at your site won't be able to get 20, or we'll have to reach outside the emergency department a little bit. So we'll talk about that during your site readiness call. We anticipate that this is going to be the hardest group to get in all of the sites. We had thought about using community controls, but that's not really the risk of people just being in the healthcare space. We had talked about incorporating some non-clinical controls from non-emergency department settings. So maybe a unit clerk on one of the inpatient units, or somebody who works at a security desk or something like that. So there's some flexibility in how we could incorporate that. But if your site has 20 non-clinical people in the emergency department, that's probably the best from our perspective. That is, still unclear about whether physicians who have already had disease are or are not going to be enrolled. Physicians who have already had the disease are not enrolled in this study. If somebody who enrolls in the study because they don't think that they've had disease and they seroconvert, that participant would be replaced in the study. But we do not intend at this time to enroll physicians who are known to have had COVID-19 infection. Operations and guidelines change fast in COVID times. Right now we split the ED, but it could change. PPE guidelines change. Is this problematic? Nope, it's gonna affect all the sites. On your facility survey, your study coordinator will get a survey every week where they'll be reporting these changes. Your study participants will also be reporting changes in their practice. We recognize that that's going to happen. We've tried to be nimble in how we collect some of those data so that if there are big changes in the way that we practice emergency medicine a month from now, that we can capture that information. But we recognize that that's going to change in all the sites, and the guidance and the availability of PPE may be changing too. Any other questions? Great questions. I think that
this is perfect, and all within about an hour. So
yeah,
that was great. I guess we didn't anticipate all the frequently asked questions, Nick, huh?
we never do. We never do.
The whole section on the freezer, you know?
Yeah. The other thing that we really want to convey in this call is the importance of this group. Having 20 sites that are invested and have a group of really smart people who think about these things is really valuable as we try to roll this study out quickly. Really, we've gone from kind of an idea to study forms in just the matter of a very few weeks. So the reason that we're intending to send out the study forms to everybody is because you're partners in this too. We really value your input. We value your experience. We value your expertise in conducting research in the era of COVID. And the feedback that we've gotten already has been really valuable. So we have this period, probably later tonight, we'll be sending out those study forms. We have this period between now and Friday that we really encourage you to look through those forms, figure out if there are things that we're not asking that we should be, if there are things that we're asking that are confusing, or there are things that we can improve, because you're a partner in this project and we really value your input.
Amen. All right. Thank you, everyone. Thank you so much, CDC, all the site investigators, our group here and at Iowa. Let's wish for good luck and that we do something and learn something important. So thank you very much. And I'll look forward to talking with you specifically when we have our site calls. Have a great evening or afternoon.
Great. Thanks, everybody.
Okay. Bye-bye.
Thank you.